The feasibility of adopting time-restricted eating varies dramatically across socioeconomic strata, cultural contexts, work arrangements, and family structures, raising important questions about who benefits from this intervention and whether public health messaging risks exacerbating health inequities. Mixed methods research combining demographic surveys with in-depth qualitative interviews reveals substantial barriers facing many populations, complicating the translation of controlled trial findings into broad public health recommendations. Employment schedule flexibility emerges as a primary determinant of time-restricted eating feasibility. Workers with autonomy over their schedules, typically in professional occupations, can adjust eating windows around work demands and maintain consistency across days. Conversely, shift workers, particularly those with rotating schedules, face nearly insurmountable challenges maintaining consistent meal timing. Food service workers, healthcare workers, and transportation industry employees often work during hours when eating is practically necessary for alertness and safety, making early time-restricted eating implausible. Multiple job holders juggling irregular schedules similarly lack the temporal stability required for consistent eating windows. These employment patterns concentrate in lower socioeconomic groups, meaning time-restricted eating recommendations risk being implementable primarily by privileged populations. Cultural eating practices and family structures introduce additional complexity. Many cultural traditions center evening communal meals as primary social and familial connection times, making early eating cessation socially costly. Caregivers, predominantly women, often eat around children's schedules or while preparing family meals, with little autonomy over timing. Multigenerational households may have incompatible individual eating preferences and schedules, requiring compromise that precludes individual eating window optimization. Food security concerns in low-income households mean that food availability timing depends on external factors like food bank hours, WIC appointment schedules, or when paychecks enable grocery shopping, not individual preference. Recommending time-restricted eating without acknowledging these structural constraints risks placing additional psychological burden on individuals facing circumstances beyond their control. The public health implications demand careful consideration. While time-restricted eating may offer benefits for metabolically at-risk individuals with schedule flexibility and autonomous food access, promoting it as a universal health recommendation ignores the lived reality of substantial populations. Public health messaging should acknowledge that meal timing represents one optional tool among many for health improvement, not a superior approach everyone should adopt. Resources should prioritize addressing fundamental determinants including food insecurity, work schedule legislation, living wages enabling schedule stability, and culturally appropriate nutrition education respecting diverse eating traditions. For populations with flexibility to experiment with meal timing, information should be available. But framing should avoid moral judgment or implications that individuals struggling to implement these patterns lack discipline rather than facing structural barriers. Research and clinical practice must work toward identifying which populations genuinely benefit from time-restricted eating and under what circumstances. Then develop tailored approaches respecting diverse contexts rather than applying one-size-fits-all protocols derived from samples of convenience.